Hi, I am Dr. Selvaraj, your surgical educator from Malaysia. Welcome back to my series of surgical teaching video class. These are meant mainly for undergraduate medical students doing the surgical clerkship rotation and the surgical trainees as well. I promise you will become competent in clinical problem solving and surgical decision making if you are going to watch these videos over and over again. Today in this episode, I am going to talk one more operative surgery procedure, namely the open abdomino perineal resection. So coming to what are the indications for this APR or abdominoperineal resection? It is for low rectal carcinoma where adequate clearance cannot be obtained by anterior resection because this rectal carcinoma is too low within 2 centimeter from the anal wedge. Then we cannot do the anterior resection, we can do only AP resection. Those patients who are having anal canal carcinoma, those who are having inflammatory bowel disease like very severe Crohn's disease with multiple fistulae, and this can also be done APR as part of the procedure of total proctocolectomy. So I have told you the indications. This is for very low carcinoma of the rectum, Crohn's disease with multiple fistulae, and anal carcinoma. Anesthesia, you have to give general anesthesia with endotracheal tube intubation. You have to put the patient in Lloyd Davis modified lithotomy position in padded Allen stirrups. Diagnosis should be confirmed by biopsy and staging should be done by contrast enhanced CT. Coming to pre-op preparation, pre-op chemoradiation treatment is indicated for patients with T3 and T4 lesions or tumors with enlarged lymph nodes that can be found out by the pelvic CT scan or endorectal ultrasound. Adequate mechanical bowel preparation should be done the day before surgery by enema. Prophylactic IV broad spectrum antibiotics should be started the day before surgery itself. VTE, veno thromboembolic prophylaxis with low molecular weight heparin or pneumatic stockings can be done. Bladder should be catheterized with Foley catheter. The stoma nurse should mark the site for the permanent end colostomy in left iliac fossa. The intra-op rigid proctoscopy can be performed to determine the distal extent of the cancer. So before going to the procedure, let us review the surgical anatomy. So this is AP resection. So we will be removing only this part of the large bowel along with the rectum. So we have to know the only about the inferior mesenteric artery. Okay, that is supplying the sigmoid colon and the rectum. We will be removing only the sigmoid descending colon junction, or maybe in the middle of the sigmoid colon we can resect the bowel. Okay, this is the inferior mesenteric artery, but usually we have to spare the left colic artery because that is the blood supply for the descending colon. So you need not ligate the left colic artery. Below that, you can ligate. This is the sigmoidal artery and this is the superior hemorrhoidal artery. Both we should ligate. And after ligating this, okay, we have to dissect this mesentery and we have to use a JAS stapler to divide the sigmoid and descending colon junction here. This is where you have to do it. So what is the position of the patient? Patient should be in this type of position. This is called Lloyd Davis modified lithotomy position with padded Allen stirrups. Surgeon should stand on the right side, of course. Incision should be a midline incision extending both above and below the umbilicus, or we can do even left paramedian incision. Exposure, the table should be tilted to the right side. Surgeon should stand on the right side. Abdominal pad should be put over the small intestine, and the whole small intestine should be retracted to the right side. Then after the laparotomy, you have to assess the position and resectability of the tumor in the rectum. You have to also assess the liver and peritoneum for metastatic deposits and colon for synchronous tumors. All these things you have to palpate and you have to rule out. Using diathermy, now you can divide the peritoneum along the white line of Tolt here, lateral to this descending colon and sigmoid colon. This white line of Tolt, you can start, dividing it using a cautery. This is what you are seeing here in both the pictures, here and here. Okay, you have to use the cautery and you have to incise this white line of Tolt. Now the next step is you have to mobilize the left colon. So you have to incise the white line of Tolt up to the splenic flexure. Mobilize the left colon from the retroperitoneal structures. While doing this mobilization, we should avoid the injury to left ureter and left gonadal vessels by placing a right angle clamp, or we can use our finger and then we can cut this area. Here you can cut it. And this mobilization is known as Mattox maneuver. This is what called Mattox maneuver. The next step is ligation of the blood vessel. Here you have to elevate the sigmoid colon and isolate the inferior mesenteric artery and left colic artery, which should be spurred if appropriate. Usually we won't ligate the left colic artery. We have to ligate the superior hemoidal artery when it is taking branch from the inferior mesenteric artery. So you have to ligate not here, here and here. This is the trunk of the inferior mesenteric artery. This is the left colic artery. Instead of ligating here, you have to ligate here. After this is branching off this left colic artery, we have to ligate this trunk only. So if you ligate this one, both the sigmoidal artery and the superior rectal artery, okay, will be cut off. This is what you have to do. So after ligating the blood vessel, now you have to transect the junction of sigmoid colon and the descending colon. You have to dissect this mesentery and use a GIA stapler to divide this bowel. Now after this, we have to do anterior rectal resection. For that, you have to put the patient in Trendelenburg book position. The surgeon should come to the left side now, and you have to extend the lateral facial incision up to the upper rectum. The incision which you made over the white line of Tolt, you have to extend it up to the upper rectum like this. Then the peritoneum is incised medial to the right ureter. On the right side also, you have to incise the peritoneum medial to the, this is the ureter, this is the right ureter. Medial to the right ureter, you have to incise the peritoneum, and this also should be extended around the rectum to join the pelvic peritoneal incision on the left side, meeting anterior to the rectum. Both the incision you have to extend here, here and here. Both should be extended and it should meet anteriorly here in this place. Now you have to proceed the posterior rectal incision. You have to carry on the dissection in the avascular plane between the mesorectum and the presacral fascia posteriorly. So you have to elevate this part of the bowel, sigmoid colon and the rectum, go posteriorly, and you have to carry on the dissection in this avascular plane between the mesorectum and the presacral fascia. So you have to carry the dissection through the Waldeus fascia to the level of coccyx. So this Waldeus fascia will be connecting the mesorectum with the presacral fascia. So you have to cut that Waldeus fascia, then only you can go up to the coccyx here. While mobilizing it laterally, you can see this lateral ligament. Okay, the mesorectum is divided laterally. Either this lateral ligament can be divided either with clamps and sutures or with a vessel sealer device such as ligature or harmonic scalpel. That is what you have to do. Here you are seeing it clearly. They are ligating it and suture ligating this lateral ligament. Okay, we had to continue this rectal mobilization to the pelvic floor level, and while doing this you have to perform the total mesorectal excision. So mesorectum also you have to remove along with the rectum. Now again the anterior rectal resection should be continued. The rectum is mobilized ventrally by dividing the rectovaginal septum in females or the rectovesical space in males. So you have to go in this space. This is a female patient, so you have to dissect here, somewhere here, anterior in between the rectum and the vagina. That is the rectovaginal septum, this one. So in male patient, the dissection plane is ventral to the denonvillous fascia so that we can preserve the seminal vesicles, and the prostate and urethra also should not be injured. So you have to go your dissection somewhere here. So in between the rectum and the prostate and the urethra. So you have to do it like this. Now the perineal procedure, we can start it. While we are doing this perineal procedure, you can do simultaneously or synchronously. Two teams can work. One can work the abdominal part of the surgery. Another one simultaneously they can start this one to save time. Otherwise, the same team after finishing the abdominal part of the operation, they have to discard all the instruments. They have to change the glove. The same team can go and do the perineal procedure also. This is asynchronous AP resection. So now you have to close the anal orifice with a 0 or number 1 silk pursing suture you have to put, and you have to close the anal orifice. Now make an elliptical incision from the midpoint of the perineal body in male patient or the posterior aspect of the vaginal introitus in female patient to a point over the coccyx. So you have to make an elliptical incision like this. So after that, you have to deepen the incision laterally into the ischiorectal fossa all around. Here laterally, and you have to deepen the incision all around. Control the bleeding from pudendal vessels at this stage. You have to carry the incision posteriorly to expose. Here you have to carry the incision here and this area, and here you are seeing it clearly. This is the anococcygeal ligament, this one. The same thing you are seeing here also. Anococcygeal ligament, the same thing you are seeing. That you have to divide it. Inside the ligament in front of the coccyx. So this is the coccyx. You have to incise here and you have to divide this one. Now the perineal procedure we have to continue. You have to use the tip of the scissors to pierce the levator ani here. Then this is what you are seeing here. Then you have to insert your finger into the pelvis. This is what you are seeing here. You have to insert your finger here and divide the levator ani muscle over it on either side. Circumferentially you have to divide all around this rectum, the levator ani. When the levators have been divided, the specimen can be delivered through the posterior part of the perineal wound. After dividing this levatai all around, the specimen, the proximal part of the colon, including the sigmoid colon, can be delivered through this perineal wound outside. The anterior dissection is facilitated now by placing a finger between the rectum and anterior structures while using an electrocautery. This is what you are seeing here. You can place your finger like this, and then you can cut this this facial attachment using a cautery. This is what you can do. Or alternatively, the anterior dissection can be completed before delivery of the specimen through the perineal incision. That also can be done like this. So without removing the specimen, you can cut these attachments first. This is in a female patient and this is in a male patient you are seeing here. With either technique, care must be taken to avoid injuring the rectovaginal septum in female patient or the prostate and urethra in a male patient. The next step is perineal closure. You have to confirm the complete hemostasis within the pelvic cavity and presacral space. This area is then copiously irrigated, typically from abdomen into the perineum. The incision is then closed in layers, subcutaneous layers with absorbable sutures, as many layers as possible, and skin with a skin stapler. This is how you have to close it with interrupted sutures, absorbable sutures in as many layers as possible. If there is enough levatai that you have to close separately. Now you have to go to the peritoneal closure. Gloves and instruments should be changed at this point in order to minimize the contamination, because now from the perineum you are again going to the abdomen. So you have to change the gloves and instruments. Drains can be placed in the pelvis and then the peritoneum can be closed, or it can be tacked to an omental flap placed to fill the dead space within the pelvis. That is what you are seeing here. This omental flap, you can place it and you can close the peritoneum, or primarily also you can close the peritoneum. The next step is the creation of end colostomy. You have to make a trifine or a hole in the pre-selected skin in the left iliac fossa. Then you have to pull the proximal end of the colon out through this trifine. The colostomy should pass through and not lateral to the rectus abdominis muscle. This is important. Cut below the staple line to open the colon. See, this colon, proximal colon or the sigmoid colon has been pulled out. Then the staple line you have to cut to open this, the colon. The opening is made large enough to avoid kinking or narrowing of the colostomy. So this opening in the skin and the subcutaneous tissue should be large enough to avoid kinking or narrowing of the colostomy. The colonic wall is sutured circumferentially to the fascia with absorbable suture. You have to make two sutures. Here you are seeing one suture here, another one here, and circumferentially all around you have to suture this colonic wall to the fascia. This you have to do with absorbable suture, of course. Then the colonic mucosa is sutured to the dermis or the skin with interrupted absorbable sutures. So here you are seeing it all around. This also you have to do circumferentially. See, this is what you are seeing here. You have to suture it to the skin. Then now you have to close the laparotomy by mass closure technique, either with onoprolene or 1-PDS. You can use it. This loop suturing technology, you can use it, and okay, you can close this linea alba. This is what you have to do. You have to start closing the linea alba either with onoprolene or PDS. What are the complications can happen in open abdominoperineal resection. Patient can go for paralytic ileus, wound infection can happen, bleeding also one of the complication. You may, during the dissection, you may injure the urinary bladder or the prostate or the urethra, or in female patient, you may even injure the vagina, that is the sex, that results in sexual dysfunction, or patient may develop some colostomy related complications like retraction or protrusion of the colostomy. All these things can, or parastomal hernia, all these things can happen. Coming to post-op care, there is no need to continue antibiotics post-operatively unless there is intra-abdominal infection. You have to ambulate the patient. That means you have to ask the patient to walk around, and then you have to start incentive spirometry also on post-op day 1 itself, because it is very important for prevention of post-operative atelectasis. Clear liquids are started on post-op day 1 itself, and diet is advanced as tolerated to soft solids. The Foley catheter is left in place for few days because of high incidence of urinary retention in especially in male patients. DVT prophylaxis should be continued until the time of discharge and can be considered as an outpatient in certain subsets of patients. So thank you very much for watching this video. If you think that these videos are very useful, kindly subscribe to this channel and share these videos in your social media. Kindly click the bell button also to get notification regarding my latest uploads. Thank you once again for watching this video. Let us meet in yet another episode. Until then, bye bye.